Hello to you all. I'm Paul Drew.
And I'm Annie Irvine.
We'd like to introduce briefly some research that Annie and I have conducted recently on language use in a rather specialized workplace setting, which is the delivery by telephone of psychological therapy. This is really the background to the talk I'll give at the live event on the 9th of July, and also for all the exercises and so forth that we've prepared. I'll look in more detail in that live presentation on language use and some of the linguistic aspects of it. But before we say more today, I just want to share with you this quotation from something that James Sanderson, who's Director of Personalised Care at the NHS England, said at a Creative Health Conference in 2019. He was promoting really patient-focused interaction and better conversations with patients to treat, as he put it, the person and not the problem. And that very much is a theme of the work that Annie and I have been doing. The NHS, he said, the NHS has a fantastic technology available that they don't use: conversation. That leads very directly into our starting point, which was that really therapy and counselling to alleviate mental health problems of any kind really is conducted largely through talk. Whatever form, whatever system is used, it is a talking therapy. So that, of course, language use is very directly involved in therapy and counselling for mental health problems. We've been studying the NHS's delivery of telephone therapy called IAPS. I'll say more about that in just a moment. And this became all the more relevant, of course, because it coincided with the latter part of the project, coincided with COVID, when in-person delivery of IAPS had to be suspended, and it's only delivered now by telephone just up to the present time. Of course, during this period, mental health issues have become much more prominent in public discourse, and no more so than among students and young people. They've been particularly badly affected, as you'll know better than we are. So we're focusing on language of psychological interventions, which will be especially relevant, we think, to your students. The IAPS program, IAPS stands for Improving Access to Psychological Therapies. This program began 13 years ago, and it's now an enormously significant mode of trying to handle as it were, the mental health, one might almost say epidemic. It's become a real problem, not only in this country, but worldwide. The NHS's IAPS program is probably the largest national program in existence for trying to cope with and manage mental health problems. The psychological therapies are delivered by fully trained practitioners and are aimed really at mental health problems of stress, anxiety, and depression. Those are the what people mostly contact IAPS for. They can be delivered, they used to be delivered by in-person meetings of various kinds. There are many forms, and Annie will say a bit more about that in a moment, or by telephone, and we have focused mostly on telephone direct delivery, which, as I say, because of COVID, has been very timely. So we're looking really at language use in telephone interactions between patients and what are called PWPs, personal well-being practitioners. They are the professionals, the therapists, as it were, on the other end of the line. And we've focused really on two main themes in our work. One about the options that patients are offered for the mode of delivery of treatment, and the other is on the personalization of the service, how these psychological interventions can be tailored to the needs of a particular individual patient. Again, Sanderson's point about treating the patient, not the problem. I'm going to talk more about personalization in my presentation on the 9th, but for the moment, Annie is going to talk about the first of those, the treatment options. And I just want to point out that Annie has a background both in linguistics, but also in social policy, and those are important really for the work that we've been doing in this area. So over to Annie.
So IAPS provision is intended to be tailored to the individual patient. Choices should be available both in terms of the type of therapy patients are offered and also the medium through which their treatment is delivered. There are several ways that treatments can be delivered, and all of these have an evidence base to show that they're equally effective. So these include group sessions in person, one-to-one sessions in person, sessions over the telephone, or sessions delivered online via some kind of internet-based platform with support from a therapist remotely. Not every IAPS service will have all of these varieties available, but where they do have a range of options, patients should be offered a choice to suit their preferences. And if you think about this for yourself, your own circumstances, you can imagine scenarios where one or other of these might be preferred by a patient for different reasons. At their initial assessment session, once the patient's been assessed as suitable for treatment and they've established the type of treatment that was most appropriate, there should follow a discussion of how this treatment will be delivered from among the relevant delivery modes available in that service. We saw in our study that therapists use different forms of language to present these options to patients. Sometimes their form of language amounted to a genuine choice for the patient to select between a range of options, but in other cases, the form of words was in practice an offer of a single treatment delivery mode, which the patient could then only accept or reject, or, as we'll see in a minute, possibly resist. I'll show examples of each on the next 3 slides, and you can pause the video if you want to read through the transcript extracts yourself before you hear our comments. So in the 2 cases here, which come from different sessions, the patient was presented with only one option for their treatment delivery. In the first case, this was a group therapy running over 4 sessions, and in the second case, the offer is of an online program. In both cases, the patient accepted this offer without question or hesitation. What's particularly notable in terms of language use is that in this first case, the therapist begins by saying, so just to go through the options. And this form of words gives an impression of choice, but we know from the full transcript that this was in fact the only option that was ever offered to this patient. In this example, the therapist again initially offers only one delivery mode option to the patient, again, a group therapy session. But here the patient resists this option, stating that they're starting to back away because the group setting would exacerbate their anxiety. And it's only in the face of this hesitancy or resistance that the therapist then offers the option of one-to-one treatment. But we might ask, had the patient not resisted, as in the previous 2 examples, would they ever have learned that one-to-one treatment was available? And might the previous 2 patients have preferred one-to-one therapy as well, had they have known about that option? And then the final, this final example represents what might be considered to be genuine choice. So here the patient was presented with all 3 available options of treatment delivery from that service before being invited to make a choice between them. So what's important here in terms of language use is that whilst patients may appear to be being offered a choice, there are subtle differences in whether they're actually being enabled to make a choice, a selection between a number of alternatives, or whether they're being invited to accept or reject a single offer. And why does this matter? So in terms of patient experience and service delivery, these subtle differences are meaningful when we think about patient empowerment and the notion of personalised healthcare. And they point to issues of power differentials within institutional or workplace interactions in terms of who has access to knowledge and information about what's possible and who controls access to that knowledge and information, who can withhold it and who can divulge it, and what implications that has for these issues of choice, empowerment and personalisation. Back to Paul to wrap up.
I hope that will give you just at least some idea, some background of the work that I'll be saying a bit more about on the 9th, when I'll be looking really in a lot more detail at some of the language use, the use of language, linguistic devices and such like that are used in telephone therapy, which I think will engage your students very much. Just to note that a caution really about the kind of data that we use. I'll leave that for you to read. But it's a matter of, these matters are of course always sensitive and can be upsetting. So do bear that in mind. We've given some references here. I want to draw your attention particularly to the third one, for more on IAPS, which has a 2-minute animation describing the IAPS process of referral and assessment, completely engaging, and that will give you more information than perhaps we've been able to give you now. But anyway, I look forward to talking with you again on the 9th and saying more about language use in this setting. Thank you very much for listening to this.